Just that we've actually got an overflow lecture theatre because we think we might need it. So if you're sitting on either side of an empty seat in the middle of the row, can you just move up, please? Because every seat is precious. I know a song about that. That's right. You can introduce yourself. Swap business cards. Yeah, you'll be there.
Space is still at the top.
Oh, at the back.
And there's about 1 or 2.
Right. Okay, am I starting? Yeah. Okay. Ladies and gentlemen. So, good morning. And thank you very much for coming. A hugely impressive turnout. We actually thought we might need the overflow lecture theatre across the corridor, but I think we've got everyone in. There might be some people coming in probably over the next few minutes. So if you have an empty seat next to you, and they're looking lost, then just stick your hand up and indicate that they can sit next to you if that'd be all right. So, hello, welcome to this 10th edition ATLS Update Day. My name's Steve Bush. I'm an emergency physician working in Leeds, and I'm the chair of the ATLS UK steering group. Just a few things to go through about sort of the running of the day. The first thing to say is that this day is being webcast, so we will have a number of people who are watching it across the globe, or probably around the UK. So welcome and hello to everybody who's doing that. If you are watching it via the webcast. You'll have opportunities of sending in questions, and if you can send the questions in by 1 o'clock, then we can sort of work out, because there's a Q&A session at the end of the day, so we can align them. There are a couple of exhibitors who are sponsoring this event. There's True Corp and Limbs and Things. They're in the Edward Lumley Hall, so if you wouldn't mind just visiting them at some point during the breaks, I think that would be mutually beneficial. And just to say that this is the 10th edition update day, which means that if you're attending here, as far as the UK programme are concerned, you've updated for the 10th edition, because there's some content changes, particularly in my talk. If you're watching it on the webcast, if you just write into the college and let us know you've watched it, then we'll assume that probity being what it is, that you have done so, and that you've done the 10th edition. And the last thing to say is we're not planning any fire drills, because why would we? So if you hear something that sounds like a fire alarm, follow the rapidly disappearing steering group out towards safety. Can I also ask if you put your phones on silent, because when it rings, it's uncomfortable for you and yours. Okay, so that's the sort of intro. What I'd like to do is give you an overview of what we're going to do today. And then I'm going to go into the talk that we've got for the first hour, which is a sort of summary of what we think the 10th edition has in store for all of us as instructors, as coordinators. So we've got this talk, which I think is going really well, ladies and gentlemen. Yes. Then Lara's going to be talking about the M-learning. M-learning stands for mobile learning, so e-learning on different platforms, in case you're wondering what the M stood for. Then we're going to have Jonathan and Hayley talking about the skill stations that have changed quite significantly for the 10th edition. A spot of lunch, which we're all looking forward to. And then Ros Roden is going to give a talk about the trauma team, which we're all very proud about, and how we've got it into the core content of the global course. And then there's going to be some feedback about the first pilot of the 10th edition that we ran in St George's from Harry as an instructor, but also Rob as the coordinator. Then we've got Lara talking about if only we all learnt medicine from the TV, what a wonderful world it would be. And then there'll be a sort of Q&A session. So that's the day, and we should have everybody out of here well before 5, hopefully by about 4:30, so that if you haven't voted yet, you have opportunity to do so. For those of you who are wondering why actually you might not be able to see, but my right leg is currently supported by a chair. It's Achilles tendon bursitis, so I don't have to say that about 100 times at lunch. Okay. So, with more hope than experience, let's go into this talk. So, the 10th edition. Every 4 years, ATLS updates the core content, updates how the course is delivered, and it's mainly, up until now, it's mainly been about the core content. The big change for us this time round is the delivery, but there are some core content changes. So for the first bit of my talk, I thought I'd just mention that. So we mentioned last year that we were, the 9th edition was pretty much aligned with the NICE major trauma guidelines. There was one slight discrepancy relating to thoracocentesis in patients with tension pneumothorax, and that sort of area has been closed in the 10th edition, and it was never a big problem anyway. So what I've done is the PDFs of the chapters that are in draft form, so not all of them have got actual pictures. I'm just using that to introduce each one, so you get some idea of the look of the PDF of the manuals. So in initial assessment, the first sort of, what I'm trying to do is highlight the changes. And there's not many changes. It's 1 litre of fluid now. And there's recognition that if patients are actually getting more than a litre and a half specifically, they've got an increased odds of dying. And there's a passage in the chapter saying aggressive and continued volume resuscitation is not a substitute for definitive control of hemorrhage. So really reinforcing that fluid management is only an initial approach rather than anything else. Transexamic is in, coagulopathy specifically, and I'll talk a bit more about that, is in. The detail about the Canadian C-spine rule and the nexus criteria are in as well. And I put down at the bottom trauma team. Now, we're going to come on to the trauma team. There's a bit of a flavour of the day of trauma team. But every single chapter now has a specific element of reflecting that most of the time in developed countries, patients are managed in teams. And so each chapter, each subject chapter has the core content and how this would affect the trauma team, or how the trauma team would particularly address the issues that are brought up by that particular problem. So you'll see that as we go through. So airway and ventilatory management, not much change. Rapid sequence intubation, the term has changed to drug-assisted intubation. There's a bit more detail about video laryngoscopy, and it's referenced as well. The glide scope, the CMAC aren't particularly spoken about individually, but there is the sort of signposting to the fact that other methods than a MAC4 blade and a strong left arm are available for visualization of the larynx. And once again, the trauma team makes a feature. Okay, in shock, and I think the pictures by and large are sort of pretty graphic, and you'll see that they are, proper. The table that we all know and love, that has been the focus of many discussions over the years, is still in, but it's been amended. So base excess is now part of it, but all other part of it is that sort of mental state where you're mildly anxious, slightly anxious, quite anxious, vaguely worried about the cat. My little joke. That's the only joke you're going to get, reassuringly. It has been changed so it's GCS rather than the sort of those descriptors. Thromboelastography is in, some detail about management of coagulopathy, but again, it's referenced in a later chapter for the detail about that. And again, early use of blood and blood products, and a definition of what a massive transfusion would be of over 10 units of packed cells in 24 hours, or 4 in an hour. And again, detail about tranexamic acid and how to give it, and of course, the trauma team. So you can see there's some subtle changes. It sort of reflects what we're doing. There's nothing that's sort of left field. There's nothing that is going, oh my God, that's a massive sort of paradigm shift in how we're going. So thoracic trauma, I told you about the pictures. Quite impressive. Recognition that tension pneumothoraces present very differently in patients who are spontaneously ventilating to those who are on ventilators. And the management is the sort of timescales of management are quite different as well. Now, who loves Atom FC? No longer. Because flail chest is now in the potentially life-threatening injuries, and tracheobronchial injury is now in the life-threatening injuries. So Atom FC could be I've written it down here, Atom CT, which nearly works, or Moat 3, because there's 3 T's in that, but I'll let you sort of do it. Or any better acronyms, please send in to the college, and we'll get that out to people. But it's quite a big change, and it's recognising that most people who have got a bit of pulmonary contusion and a couple of ribs broken in a couple of places and all the rest of it aren't actually those sort of just about to sort of become terminally hypoxic, but somebody with a large tracheobronchial injury is at very high risk of not being managed successfully. The other big change is needle thoracocentesis. This builds on Simon Lee Smith's work. About 10 years ago, Simon presented to the update day in this room about his work regarding the length of a venflon and getting access to the pleura. And that's sort of, embedded now, so that in an adult the fifth intercostal space is now recommended for thoracocentesis if you're going to do it, although there's recognition that open thoracostomy is probably a better approach, which again aligns nicely with what the NICE major trauma criteria are suggesting. There's a more detailed algorithm for sort of thoracotomy in cardiac arrest, and the size of the chest drain recommended is shrunk. And there's some detail about how to manage blood pressure with aortic rupture, talking about esmolol, talking about nicardipine, talking about GTN. And again, the trauma team makes a feature. Okay, so going on to abdominal trauma, the high-riding prostate is no longer recommended as a sign for urethral injury. If there's concern about urethral injury, it's retrograde urethrogram. PRs are still important for blood, for tone, for palpation of pelvic fractures, but that it's no longer recommended as a sign for whether you can detect urethral injury with a high-riding prostate. And there's a sort of slightly amendment made to the flowchart with pelvic fractures. And once again, the trauma team, as applies to pelvic injury and abdominal injury, it makes a feature. Okay, so head trauma, and the GCS guidance has changed very slightly in the fact that we're no longer inflicting pain on people. We are applying some pressure, which, if you're a patient, you go, okay, that makes sense. There's some detailed management on blood pressure management, as I mentioned before. Minor head injury has now been changed to mild. And this is where the anticoagulation reversal guidance sort of, if you're on one of the more novel anticoagulants, what you can do and what you can't do, etc. It's quite detailed and it's quite useful and easy to follow. And again, some more drug guidance. So there's more sort of drug names and drug classes in the 10th edition than really we've seen in previous editions. And again, trauma team in there. So for spinal cord trauma, the myotome diagram has just changed. It makes it simpler. It's each level has one thing to do rather than a bunch of different things. So it's easier to memorize when you're doing your secondary survey demo. But of course, we'll come on to the secondary survey demo because that's one of the change skill station. The term C-spine immobilization has been dropped because it's not immobilized. We reduce its range of movement. We don't get it to zero. So that's the sort of accepted term now. And as I mentioned before, the Canadian C-spine rules and the Nexus criteria are actually in there in full to identify which patients don't even need imaging. Trauma team, I'm going to mention that every single time. That's how proud I am of the trauma team chapter. Okay, now, that's a good pick, don't you think, ladies and gentlemen? There is a foot in there, spot it. I think it's fantastic. So the only changes in there are a weight-based antibiotic regime together with a sort of classification of open fractures, less than a centimetre, 1 to 10 centimetres, or sort of severe soft tissue damage, and a sort of highlighting that if somebody's got bilateral femoral fractures, their increased risk of death is much greater than just doubling the fact that they've got two rather than one femoral fracture. And the trauma team is once again highlighted and noted. Again, you're not going to miss that, Bernd. The formula has, it's the Parkland formula, it talks about 2 to 4, it's now 2. So it's 2 mils per kilo per percent burn in adults, 3 for kids. Again, titrated to urine output, saying that that's just a guide to whatever, but adults need to pee out 0.5 ml per kilo per hour, kids 1 ml per kilo per hour, and recognising that in the developed countries, we do it in trauma teams. I keep looking at Ros at this point. Oh, I'm not looking at Ros. I'll look just above her head. That's very disconcerting. Right, we haven't got a pick for paediatric trauma because these are the draft PDFs. They haven't, the complete sort of materials have yet to be done. But I just thought it would be nice to. We expect that most of this stuff is sort of settled down. So most of us in the UK already use dope mnemonic for sort of concerns with ventilation, displacement, obstruction, pneumothorax, and equipment when you're having problems with an intubated child. And that's now sort of, as I say, referenced in the manual. The second intercostal space is the preferred place for kids for needle thoracocentesis. And again, 20 mils per kilo is a single bolus, and if you need more, then you need blood. And there's a sort of, if you follow the 8th edition, 9th edition, 10th edition, there's a sort of evolution of that message. Trauma team. Okay, geriatric trauma. And can I just say, up until yesterday, I was wearing a pair of Crocs, okay? I'm embracing my middle age. So the thing about the geriatric trauma that's changed is the fact that there are 5 conditions on the left there that are particularly associated with increased mortality with all spectrum of injuries in the older person. And pelvic fractures are highlighted as ones that even minor pelvic fracture in an elderly person increases their mortality by, you can see, 4 times, rapidly, hugely increases their length of stay and demands for transfusion. And we will look after these people in a team. Okay, with pregnancy, not much change, just sort of the amniotic fluid pH is there. That might be a feature of one of the MCQ questions. And we'll come on to the MCQs in due course. No, I'll tell you about them now. What the heck? I can always come back to them while I'm remembering. We've been through the papers 1, 2, and 3, which are the new MCQs. And to be honest, there are very few questions where there's uncertainty or difficult to interpret, or just basically, you know, I disagree. They all seem to be absolutely right and appropriate, and you can see why the answer is what the answer is with the core knowledge in the background. Okay, and then a transfer, nearly lastly, it would normally be lastly, transfer to definitive care. Specific mention of don't CT patients in the primary hospital if they're going to a sort of major trauma centre and then going to have a CT there. In the UK, that's a message we need to give, although often people will have that because trauma units will still have very easy access to CT. But around the world, primary hospitals may require quite a lot of setup to get a CT scan and don't have the same image sending abilities that we have in the UK. So the message is, though, you don't want the patient to undergo a trauma CT twice, and you don't want them to delay. And there's a specific template for communication on the SBAR format. And trauma team. There is a chapter, an addendum chapter it's referred to, written by Ros Roden and Hayley Allen, that is now an embedded part of the global programme. This is the biggest content change the global programme has ever had. And it came from those 2 individuals sitting on the front row here who have been recognised for their efforts. It's in there. It's embedded throughout the course, and it means that the ATLS programme can meet the criticisms that sometimes levelled at it, that we work in teams, but you're teaching a single person. We need to teach the single person because occasionally you are on your own. I was involved in the Great Heck rail disaster, the Selby rail crash in 2000, where I was on my own, surrounded by 20 people who were also on their own. But most of the time we work in teams. And what's lovely is that this is a screenshot of Ros's talk in this room in 2014 when she was talking about what is planned for the next edition of the ATLS programme. So from that day to this day, we've actually delivered a really great product. And Ros is going to talk about that this afternoon, I think just after lunch. So that's the content change. Not a vast amount, just some tweaks, just some subtle evolution of the programme, which is deliberately not set up to be at the cutting edge of trauma research, but it's a solid body of evidence. What's changed? Well, just about everything else has. This is the biggest shift in how we deliver the programme since it started in the UK in 1988, since it started worldwide in the early 80s. This is large. And the nuts and bolts are that it's now an M-learning supported. So remember, M-learning, mobile learning, so like e-learning, but on a whole bunch of different platforms, and face-to-face. And the M-Learning the courses are called the hybrid courses, and the idea is you do 13 modules, that's 13 hours of pre-course work, and then come on a 2-day provider course, so 2 full days face-to-face. And we expect that all candidates will have done the M-Learning before day 1 of the 2-day face-to-face. There are a whole bunch of materials, and I'll go through them in a sec, but there's the M-Learning modules, which are available at any time. You don't get locked out of them. You have access to them even after your course. You've got open access to those materials. The 9th edition was in an iBook and an eBook, an electronic book you can look on your laptop or on your tablet. Well, the 10th edition will be the same. There will be PDFs of that, and in fact, there will be a hard copy produced. We don't expect the hard copy to be sort of the default manual that everyone's going to use, but it will be available. So if you do want to have one next to your 6th, 7th, 8th, 9th edition manuals on your bookshelf, then it will be possible. Although we're saying it's that the 2-day face-to-face course, it's mainly skill stations. There is one. We think that it's important to have one plenary session. So we'll go on to the detail of how we piloted the first course, which we did in May of this year. And there's one interactive discussion for the whole course of either 16 or depending on the number of candidates. But after that, that's it. We don't have lectures. And that's the big change. So M-Learning is in, so that people should not require to have the lecture element. That's the big change. So you don't have the course together as a whole apart from that first plenary session. And that does change the dynamic. And a lot of what we're going to talk about today is our experiences of piloting that. And the last thing to say is that the skills stations have undergone the biggest change that's ever happened. The skill stations have largely been unchanged since the mid-80s, really, as far as how we teach them. And the skills that we are going to be teaching in the 10th edition, I'm talking about the whole global program. This isn't just the UK deciding to do this, that, and the other. This is the global program. The skills within the skill stations are pretty much the same, but how they're grouped together and how they're taught is the big difference. So I don't want to steal anybody's thunder, but there's a bit about sort of repetition and just sort of reinforcing certain things. The skill stations now are all using an unfolding scenario because the idea is the idea is that people learn better when they've got some context of the skills. Now, often, a lot of people are already doing that. You make up a scenario and you say this, that, and the other, but it's quite heterogeneous. It depends on who's doing it and what day. And there's recognition, well, actually, let's try and get some guidance to instructors so we've got a scenario that will just unfold. And Jonathan and Hayley will talk about that later on. We've also got some real clarity on which skills are taught in the 4 stages and which skills are a demo discussion, because there's a difference. So highlighting that, and again, that will come out in their talk later on. And we will, we are working on some very specific, easy-to-follow guidance that will be used throughout the UK, certainly for the next pilots that we'll be running, to allow instructors to read it and get, I get what I'm doing on breathing, I get what I'm doing on circulation, rather than a very, very comprehensive suite of documents that's really for reference only. Okay, so the skill stations. There are 7 skill stations on the 2-day course, and I'm going to show you how we sort of ran the pilot course, sort of the nuts and bolts, to give you some context about how to put this together in your own mind. So airway is pretty much the same. A basic, advanced, and there's a surgical element. But then there's a breathing skill station, a circulation skill station, a disability skill station. You can see the philosophy behind this. But then a secondary survey skill station, not a demo. An adjuncts skill station, when I go through what's in one, I think it'll be a bit easier. But then the last bit is the trauma team skill station. So, what's in the airway skill station? Well, not much has changed. The basic airway is some discussion about demo and the airway assessment, etc. And then the adjuncts with suction are 4 stages, bag valve fast ventilation, 4 stages, and a discussion about the pediatric differences with the basic. Then advanced, well, it has the 4 stages is the laryngeal mask airway insertion, but then demo discussion, hands-on if time's available for endotracheal intubation, bearing in mind that we do not expect people to leave a UK ATLS course having gained competencies in intubation that allows them to practice on human beings. Okay, so it's a demo only. And the last bit is what we call the surgical pediatric airway. Again, it's a bit about going on to focusing really on the surgical element of the needle crike and surgical crike as the 4 stages. So that's airway, hasn't really changed. And that's an hour and a half, putting all those 3 things together. Breathing, so there's some specific wounds or specific injuries that need demo and discussion, but the 4 stages you recognise as needle thoracocentesis and chest drainage insertion. And shock, the skills in there. There is one new skill actually, which is wound packing, second one down. There's a beacon course, a bleeding control course that's gaining some momentum in the same way as we've got defibrillators in public areas. There are certain parts of the world, America's one, where they're starting to put bleeding control packs because of mass casualty situations and teaching the general public about certain things like how to actually press on something to stop it bleeding. So there's a specific discussion point, and that's one of the new bits in the 10th edition about how to manage, say, a bleeding, hosing out groin wound, for example. But the rest of the skills are unchanged. The 4 stages of interosseous and femoral access you recognise from a shock skill station. Okay, disability. We're calling it a skill station, but our experience is that it's a demonstration discussion. But one thing that worked quite well was doing log roll, and you've got enough time to do a log roll where everybody does everything on a log roll. So you have to do it 5 times so that everyone's the patient and the log rollers. And that's one way of getting the log roll bit into the program. And there's lots of the other skills you'll recognise from the 9th edition and 8th edition courses. We're just putting them in a slightly different format. A secondary survey I mentioned is no longer a demo, it's now a skill station. It includes the collar sizing and application and discussion of some of the elements that were in the musculoskeletal skill station, particularly open fracture management and compartment syndrome. The adjunct skill station is really X-ray interpretation with a discussion about ultrasound. So again, the skills in there are nothing new. The trauma team. Now, the trauma team is new, and the trauma team skill station, Roz is going to go through it in some detail. We've got a video that's been prepared, and then it's going to be a sort of facilitated, scripted discussion about the trauma team, so that we wanted to keep the team element of an ATLS course in a sort of itself contracted, just you're doing that bit of trauma teams, so it doesn't embed itself throughout the entire course, so people are confused when they're doing the moulages, am I supposed to be in a team or not? So having that sort of specific time of the course is really valuable, recognising the importance of working together. But then when we get onto moulage, we go back to a single person running the show. Okay, so a little bit about the materials. Mobile learning, Lara's going to be talking about that straight after here. 13 chapters that fit with the 13 core chapters of the manual, each split up into a smaller number of lessons. Each chapter comes with a PDF that you can download, you can print out if you want. and as I said, an electronic version of the manual that's got hyperlinks, it's got embedded videos, and the MATLS app, which I'll come on to again. So these are just some screenshots of the M-Learning, and Lara's, as I say, got much more detail in there. It's worked with the University of Michigan in the same way that ATLS content is tried and tested. It's not groundbreaking, it's not cutting edge. The the M-Learning is very much state-of-the-art in adult education. So that collaboration with the experts in the University of Michigan have borne a lot of fruit. And it's video, it's interactive sort of sessions, it's sort of some very easy to understand graphics, and sort of covers quite nicely the sort of full range of topics that we think that our candidates need before they attend an ATLS course. So the manual, as I said, it's an e-book, it's an iBook. If you want to purchase a hard copy, it will be available. In the same way with the 9th edition, most people didn't have them. The candidates did, but the instructors didn't. The 10th edition, the hard copy will... We're not actually 100% certain, let's tell you, to be honest, but we think that the hard copy is not going to be the default thing to give out to people. It will be available in some form of electronic format, but that element of it is still being worked up. We're just waiting to find out. And I'll tell you about the timeline towards the end when we know sort of the rollout. It'll be next year, but we've had some drift of the timings, which is why we had the update day in June, but we've got a bit more time to work on it. Okay, so these are screenshots of the chapter. You'll recognise the front page because that was the one I used for when I was going through the core content. And easy to read, nice colours, formats, something you recognise from doing reading any of the manuals in the past few years, and it follows the same sort of concept. So just one thing about the ATLS app, the My ATLS app. George Brighton and Wessam Abuznezar, who is a guy from Saudi Arabia. The two of them have been working on this incredible app for a number of years now. It's been downloaded over 200,000 times. It's been downloaded in now 160 countries. And when ATLS is only in 83, recognise the value of this thing. It's got videos in it. It's got skill stations in it. It's got chapters in it. It's got some resources such as the Parkland formula calculator. And it doesn't replace any of the other materials, but it's a great augmentation when you've been through an ATLS program. It's currently sort of set on the 9th edition content, so it'll have to be updated. It's already on update, I think, 2.1. And so there'll be version 3 coming out. If you've not downloaded it, I highly recommend you do. It's on Android, it's on Apple. The unlock codes for the full content are on the inside of the 9th edition manuals, or if you have to pay for it, I think it's $10. So what's that, about £8? In the olden days, that used to be £5. Remember the old days of 2 for 1? Oh. Great days. So if you haven't done if you haven't downloaded the My ATLS app, please do so, because it is truly fab. So what's not changing? Well, the philosophy, the sort of message, how people are injured and how to make them better. The triage discussions, there are some new ones, but they haven't changed them all. So if you like the explosion in a gymnasium, that's the one we used for our the pilot course, and I just put it in the context of the David Lloyd, because everybody was a doctor. And the moulages, there have been some changes to the detail about it in fitting with the 10th edition, but the concept of MCQs and moulage haven't changed. Can we just have a show of hands, actually? Because we've been talking about sort of augmented moulage and the use of simulated monitors for a number of years now. If you're in a centre that uses them, would you just raise your hand, please? Okay, so a number, but certainly not all. They are incredibly well received by the candidates. The idea of not being told the saturations and told the blood pressure because it's there, and having those audible cues as the saturations drop or the heart rate increases. And you can go out all guns blazing with the very expensive bespoke ones, or you can do as Babek mentioned last year, spend a tenner on an app and just link it up to your mobile phone. So all you need is a tablet, either an iPad or some other, and it works really, really well. So if you're thinking about it, then I'd really strongly suggest you do it, because for the centres who do use it, there's no going back. Okay, so other elements, what will be changing? The re-verification course is already pretty fit for purpose for the 10th edition. It's actually sort of ahead of the game if you look back on it. There'll be some tweaks that need to happen to make that fully aligned with the 10th edition, but we don't think there's much in there that needs to happen. Instructor course, again, in the fullness of time, that will evolve once we understand exactly what the 10th edition programme is demanding of the new instructors for that. And of course, when it's time to recertify as an instructor, you won't have to give a lecture, because they ain't none. So pressure's off. Okay, so what I thought I'd do is I'd give you a bit of a narrative of our experiences running the first version of the hybrid course in the UK, which was in St George's, and I'm grateful for the St George's team, and Rob from St George's is here to tell you about his own bruises about doing something very different with a whole bunch of willing people who are all willing to thrust themselves into the unknown. So it's a 16 candidate course. The candidates were told it was a pilot. The candidates told that between the faculty we had something like 750 courses under our belt, but 0 on the 10th edition. So everybody went into that in a bit of a spirit of right, let's do this, and let's get the best out of it possible. So the first thing that we did was recognising the start time on day one is much earlier than a normal course. Normally, most people start at sort of 9:30, 10 o'clock on day one. So starting at 8, 8:30 was the usual intro, introduce yourself, my name is, my mentees are, that sort of stuff. And then that plenary initial assessment discussion, which is the only course-wide group that sort of happens on the entire 2 days. Then we just put in a 10-minute gap to move to skill stations, and then went on to the skill stations. Now, you can see here that we actually ran all 4 groups simultaneously in parallel tracks from basic, advanced, and surgical. That worked because we had the capacity to do it, we had the infrastructure, we had logistics support. We recognised that if you wanted to do that with a 20 or a 24 candidate course, that's going to be really difficult. So what I've got is, after I just show you about these ones, there's a bit of first cut about how we would do it on a 24 candidate course, which we're going to do on the sort of refining pilots later on. But so far, so good. Courses, the skills we were teaching is pretty straightforward in groups of 4, and it was fine. So then what we did was we had the breathing skill station, circulation skill station, and so again, kept the 2 groups of 4 an hour. So 2 groups did breathing, 2 groups did circulation, have a spot of lunch, which was very nice. Thank you very much, Rob. It's important, and at least to me. And then we'd do this, swap the groups. And then we had an MCQ discussion for half an hour, going through the MCQs and the sort of interesting questions. Not many again, would you mind, show of hands, who does a specific MCQ discussion thing on their courses? So probably the minority. Okay, so recognising that we probably can drop that and do it in a different way, having so some courses just have the MCQs around a big room where people have lunch in. There's loads of different ways of doing it, but we thought, what I should say is that we were called the beta pilot, because the alpha pilots were done. 3 were done in America and 1 in Australia for the courses. 2 of the hybrid courses and 2 of a different approach with lectures still in it. And what we did was we took their alpha course schedule and then modified it for what we thought would need to be done in the UK. But we're going to further modify it once we've got the learning from this experience. And then we moved to skill stations after that MCQ discussion. And again, the secondary survey and the disability skill stations for an hour, and then just swapped over. And that was the end of day 1. So day 1 finished at 6 o'clock and started at 8. So day 1 is quite a long day. And we'll come on to the impact it had on the sort of faculty, etc. But it's pretty knackering, and there's not much downtime. And if you think about it from a coordinator perspective, there's quite a lot of changing around without much time. You don't have the lectures to give you that gap to do things. So it's about having to prepare perhaps ahead of time so that you've got a number of different things ready to go in a room in different parts of it. But logistically, it's really important to think through. Okay, day 2. So we started, in fact, day 2 was slightly different to this. Day 2, we took the decision to show everybody the video, which is a 20-minute long video, which you're going to see later on today, with some very polished performances by highly regarded members of the steering group. What was good for that video was it was the sort of, you could see people visibly relaxing and just sort of reflecting and thinking rather than always sort of in that sort of skill station scenario. Then we split the group into 2 halves and had a focused discussion on what they'd seen, their own experiences and their reflections on the 2 combined. Then we split the candidates into 2 groups of 8 for adjuncts because we thought we'd try it. We remember the adjuncts is the X-rays, ultrasound, but 8's too big. So we're not going to do that again. You really need to keep your groups to 4 really maximum for these sort of interactive discussions. And then we went into a break, and then a lot of it sort of gets back to sort of comfortable ground in the fact that we had the faculty demo of moulage that we'd normally do on day 1, but we put that in on day 2 because we thought, right, okay, we're now getting on to moulage, faculty demo of moulage, then moulage practice in groups, which we'd normally do on day 2 of a provider course, and then going into what you would recognise as the last day of any course, which is MCQs, triage discussions, and moulages. So it was a big sigh of relief once we started doing practice moulage because we were properly on well-trodden ground and very familiar ground. So that was the sort of nuts and bolts of it, and Harry and Rob are going to talk a bit more detail about the experience of the course and what we've taken away from it, but I thought it'd be helpful to give some context to that. Now, I've mentioned that the way that we did that wouldn't work for a 20 or a 24 candidate course because there's just too many parallel tracks. And so we'll make these available, so I'm not expecting you to sort of interpret them as you see it on the fly. But in essence, at the top, we split the course into 2 halves. One half does the airway stuff, and the other half has the initial assessment interactive discussion and a faculty demo. So for these courses, what we're saying is you do the initial assessment demo and the initial assessment interactive discussion twice, which we've never done before. But if you do that, then you've got a manageable size of individuals doing airway skill stations, and you don't need to have 6 airway heads and 6 lots of this and 6 lots of that. We did feel it would be reasonable for everybody to do the surgical airway together because everybody has their own larynx. I'm not referring to the one that's attached to them, it's the one that they get on a course. That was a joke. I think I need a signpost. Harry, can you do the honours? Yeah. All right, okay. So I thought the delivery of that was great. So we thought everybody, because people are having their own kit, it was probably not unreasonable to put everybody does the surgical airway simultaneously. And after that, to be honest, the course can run quite easily. You just need, obviously with the larger course, you need more breakout rooms because you need to keep each group to a maximum size of 4, apart from the sort of trauma team discussions where that can be a bit bigger. So there's some work's gone in already to plan the next phase, because what we are clearly not in a position to do is to say we've tried it once and it's ready to go. So every course centre in the UK, crack on, because there's so much change in the delivery of the course for this 10th edition, literally the biggest change since it came to the UK, since it started out in Nebraska, that we've got to approach it quite sensitively. The UK programme was asked specifically to do that the first course out of the US because of the sort of robustness of our programme, and we're sort of still leading the way. So ATLS Europe, which is an organisation of 22 countries around Europe, we're sort of leading that group through this very sort of interesting and quite challenging time, so we get to a point where we can deliver the 10th edition programme knowing that our candidates are going to get a good experience. So last few slides really, the impact on faculty is you don't know your candidates as well because you don't see them as often, you don't view them in lectures, and depending on the schedule you might not actually teach one particular candidate. You probably will, but you might have less exposure to some and more to others. Our experience of faculty, and Harry will sort of reinforce this, is it's pretty tough. There's no downtime. You're not sitting in a mate's lecture, or when the lecture's going on that you know well, you're sitting in the faculty room and just chatting. You're full on the whole time. And there's recognition that if we don't do something different, it's unlikely people will be coming back time and time again. So we have to build in breaks, sort of specific breaks for faculty. And of course, you're not listening into someone else's lecture, so you're not stealing with pride all those little bon mots that you hear someone else do and say, I'll have that, that's mine now. So there's less that peer-to-peer learning. And the new skill stations, again, are ones that you need to learn, and the new and our sort of development of the guide to faculty, I think, will make that a lot easier. Okay, for candidates, now we've not got a candidate. Ideally wanted a candidate on the hybrid course to come and to speak, but none of them wanted to do so. Scary bunch. But their feedback is, again, pretty much as you'd expect. It's full on. There's not much time to reflect and think and sort of process what you're seeing. And of course, if they haven't done the M-Learning, there's going to be very little opportunity for them to catch up, because it's not like a lecture where you can sort of pick up stuff or ask a question about sort of a more esoteric stuff. It's all skill stations hands-on. And the coordinators, and probably the biggest impact is on coordinators, is, whoa, completely new sort of program. Kit might need to purchase, maybe certainly for the surgical skills stuff. There's not vast amounts, but there is a difference, and just understanding that. But I think the biggest thing is about the limited time to change over from one skill station to another. So the implementation, I mentioned these alpha pilots. These went on in 3 in the States and 1 in Australia, but it was sort of an American-style course. They happened in early 2017. We did the beta pilot just over a month ago. So we're calling it the refining model. In other words, we've got lots of learning from the experience in St George's. We're going to trial on 16 candidate course and 24 candidate courses in October and November. So we're going to do 3 further courses with a mix of faculty who've been on the original hybrid pilot course and people who are just sort of experienced instructors, because the learning trajectory is not yet flat. And we think that the national rollout will be around September of next year. The uncertainty is that it depends. Sorry, what did I just say? September. I don't know my months. Sorry. February. Sorry about that. February of next year. We're not sure. It very much depends on the sort of completion of all of the M-Learning modules that are not quite done yet. So we're sort of, it's the global program, the global M-Learning is being launched. So we've got to make sure that it's embedded, it's working, it's consistent, it's stable. As BA know that an outage of IT is a problem. And certainly if you're running a global program, you've got to make sure that your infrastructure, it works so that whatever happens, candidates can go on that learning at any time. So last slide, really. Just on that learning at any time. So last slide, really.